Hi guys, it's Miss Carter again. Okay, now we are going to do chapter 11 and 12, which is growth and development of the school age child, and lastly, growth and development of the adolescent. Do keep in mind that this lecture will be more than an hour because it will cover both chapter 11 and 12 within this same video. So if you do need to stop, pause, rewind, or come back to it, you may do so at any time. That is the purpose that I started recording them for you guys. Hopefully this is a better alternative for you and you can listen to them at your leisure. Please, please, please do try to listen to the lecture prior to coming to class on next Thursday, as I would like for you guys to have questions, comments, or concerns regarding the material instead of you guys not being prepared. So please, please do try to come prepared for class next week by reviewing this lecture and taking any notes and jotting down any questions or concerns that you may have in regards to these two lectures. Well, this one lecture. Good luck, and here we go. Welcome to chapter 11 and 12. During these two chapters, we will be talking about the growth and development of the school-age child and then the growth and development of the adolescent. These two chapters will serve as your last two chapters for growth and development, which I'm sure you will be very excited about, seeing as to where it gets very confusing trying to remember and learn all of these stages and growth of development for all of these ages. So, as we start, we will go through chapter 11 first, which will be growth and development of the school-age child. I do want to make note that within these last two chapters, you want to try to tie together all of the stages and all of the theorists and see if you can come up with a way to make a smaller, more convenient chart for yourselves as to what they do in each age, so that it'll be easier from here on out as we go back and review growth and development. As you may know, it will get a little easier as we go into the disorders and disabilities and the chronic conditions of the pediatric patient. And you won't have to know so much about growth and development, but you will have to have an understanding of what they're able to do at each age, so that when we do start talking about their ailments and disorders, if there's something out of the ordinary, you will have to know what the normal is, such as a 3-year-old being able to say, 30 or 40 words and things like that. Whereas if they have a hearing condition, they may only speak 2 or 3 words. So things like this we will talk about. But for now, we will stick to the growth and development of the school-age child and the adolescent. Alright, let's look at the school-age child. And you want to note that this phase of development is from about 6 years of age to 12, and it is crucial to establishing positive self-esteem, a sense of belonging, and feelings of competence. During this time, the child moves from egocentric thought to experiencing the world through peers, online social networks, and the school environment. When we look at the physiological development, a vital mechanism influencing physical development during the school age is their growth hormones, which stimulate cells throughout the body. The brain is usually adult size by 12 years. You also want to note during this time they may notice as the school nurse or even as the primary pediatric nurse that if they have a lack of growth hormones, they may have a growth hormone deficiency, which we will talk about later. When we're looking at the musculoskeletal, you want to note that during the school age years, the child's weight increases by 7 pounds per year and height increases by 2.5 inches per year. At 6 years, the average boy weighs about 45 pounds and is about 46 inches tall, whereas the average girl weighs about 43 pounds and is 45 inches tall. By 12 years, the average male weighs 88 pounds and is 59 inches tall, and the average female weighs about 91 pounds and is 60 inches tall. When looking at skeletal growth, it is particularly noticeable in the long bones and extremities. The child during this age may experience what we call growing pains. This commonly occurs between the ages of 8 and 12 years. Girls are affected up to 2 times as often as males, whereas you would think it would be the opposite because males usually grow taller. Boys have a greater number of muscle cells than girls, so it is common to find they do well with gross motor activities, such as throwing and running, hence why a lot of males play football or run track or play basketball. In contrast, girls tend to have better dexterity with their fingers and hands, so they are able to act at fine motor, which is the small muscle skills, during the school age years. As eye-hand coordination and motor skills improve, the school-age child is able to write, tie shoes, and become autonomous in dressing themselves. The average apical pulse rate for the school-age child is about 90 to 95 beats per minute while at rest. The average respiratory rate for the school-age child is 20 breaths per minute while at rest. Now note that this will fluctuate. That's just an average, so you don't want to freak the parents out if you do have a school-age child that has a lower or higher heart rate or respiratory rate. Now, you will notice for your athletic school-age children, their heart rates will be significantly lower than the 90 to 95 beats per minute. You also want to note if the child has a murmur, and you can look in your text on page 333 where it talks about an innocent heart murmur. You want to explain to the caregivers that an innocent murmur is created from the sound of the blood flowing through the heart and can be heard because of the child's thin chest wall. You want to reassure the child and the caregiver that the murmur is not associated with heart disease and will no longer be heard when the child reaches adolescence. You want to provide the school nurse with medical documentation confirming the presence of an innocent murmur. So this is why it is very important to have the child taken in for the well care visit so that they do note this within the school. And this is important to also note when the child becomes active in activities. You want to provide athletic coaches with medical documentation confirming the presence of an innocent heart murmur as well. You also want to know that during the preschool years, children are exposed to and develop immunity to various microorganisms. Therefore, by the time they get to the school age years, they are often among the healthiest phases in life. So this is usually an age group that does not get sick very often. Antibodies are produced by the lymphatic system and reach their peak by 7 years of age. Because of the increase in body size and maturity of the immune system, the school-age child is able to respond to illness in a similar manner of an adult. When we look at the psychosexual development, which is Freud, starting at age 6 and throughout school age, the child enters a calm period in the development of sexuality called latency. Freud identified this child with same-sex parent by modeling the behaviors and emotions of this parent. If you need a review on this, you want to look back at chapter 6. You want to note that the child also learns about sex role behavior and identity by observing caregiver interactions, the media, and friendships with children of the same gender. Looking at sexual development, the last years of the school age period are called prepubescence, meaning 2 years before puberty. You want to note that the first physiological signs of prepubescence, such as breast tissue development, this usually appears between 8 to 13 years of age in females and from about 10 to 14 in the male. Going over to psychosocial development, the school age years introduce the child to a world of peers and school. A newfound independence from caregivers is discovered, and peers become the major socializing agent. Although school-age children need the love and support provided by caregivers, peers provide support needed to gain independence from family and are central to the development, as increased amounts of time are spent with peers of the same gender. At age 2, children interact with peers 10% of their day. By ages 7 and 11, children interact with peers more than 30% of their day. So you can see the difference in percentages there. And you also want to note that during this time, energy is channeled into activities such as school projects, sports, and hobbies. In order for the school-age child to feel a sense of competence, it is imperative they have a positive relationship with an affirming adult. If unable to receive the support needed from caregivers or teachers, a school nurse, club leader, or coach may be instrumental in instilling this positive sense of competence. When we look at self-concept, the development of positive self-concept and self-esteem are also critical at this time. Self-concept is influenced by physical appearance, athletic abilities, academic achievement, approval from caregivers, and shaped by comparisons with peers. The closer the perceived self is to the ideal self, which is how the child would like to be, the higher the child's self-esteem. Acceptance by peers also influences a child's sense of self-worth and healthy body image. A child with low self-esteem may be self-critical, feel shame and inadequacy. They may show signs of regression and have an increased risk of depression, anxiety, resentment, and even eating disorders. So when we're looking at the psychosocial development and looking at self-confidence, when we talk about the school-age child, one thing you want to make sure you're educating the parents on is that they must have consistent rules and expectations. And if this is occurring within the home and even outside of the home, the child should be and will be expected to be confident. Now we will look at the cognitive development. Expanded cognitive abilities enable the child to to imagine the world without having to experience it. However, because abstract thought has not yet been developed, the child is limited to thinking concretely and in the present time frame. During these concrete operations, the child gains the skills of classification, the ability to group items according to common characteristics, conservation, which is the ability to acknowledge that a change in shape does not necessarily mean a change in amount, and reversibility, the ability to recognize that actions can move in reverse order. And one example of this is if you want to look at the conservation of weight, what you could do as the pediatric nurse or even as the school nurse to get the child to understand this, or they actually will understand that a pound of oranges and a pound of bricks weighs that same pound. They will understand the conservation of weight by knowing that a pound is actually a pound no matter what substance they are weighing. They should be able to count, say, 5 oranges and note that that's a pound, whereas it may only take 2 bricks to make a pound. They will still understand that conservation of weight and know that each substance does weigh a pound regardless of the number or the substance that it is. When we look at language and reading, by age 6, the school-age child has begun to master grammatical rules of language and has a vocabulary of about 10,000 words. By the end of the school-age years, the child's vocabulary exceeds 40,000 words. In addition, by 6, the school-age child uses 6-word sentences and can follow a story without the use of pictures. By 7, the school-age child understands time and the difference between right and left. The 8-year-old child can use language as a tool for reasoning. By ages 11, metaphors are understood and used in conversation. Besides a tool for communication, language becomes a tool for socialization, as the school-age child's language becomes less egocentric. So your 7-year-old will also know right from wrong. And you also want to note that the child will have an increased attention span and can be interested in a particular activity for a long length of time, whereas your preschool child could not concentrate for that long. When we look at Erickson's theory of development, which was psychosocial, we want to note that the child is in the industry versus inferiority stage. And an example would be that the child would sign up for an after school activity. They are developing their own sense of worth. And with that being said, they may become in activities within the school, within home, or even activities within the community. And this would be a good example of the child mastering the industry stage versus inferiority. Lastly, we will look at Kohlberg's moral development. And during stage 3, the child's morality is based on avoiding the disapproval of others and maintaining a positive relationship with friends, family, and teachers. Accidents can be viewed as punishment for disobeying. Older school-age children understand the need to treat others as they would like to be treated. Let's now look at health promotion and maintenance. When we look at nutrition, during the school-age years, the child becomes aware of how the body works and can more fully understand physical development and how to remain healthy, because a steady rate of physical development is also occurring at this time. We also want to note that obesity is still a major problem, and the obesity rate for school-age children has quadrupled in the last 4 decades. Obesity is considered the most serious health risk facing children in the U.S. Yet, most parents of overweight children tend to underestimate the child's weight problem, or they may too be overweight or obese themselves. Remember what I said, that teaching good eating habits begins usually in the toddler to preschool age. Childhood obesity presents a variety of physical health problems with long-range proclivity for hypertension, heart disease, diabetes, cancer, and sleep disorders. And the sleep disorders that they are referring to is usually sleep apnea. However, the early school age period, ages 5 to 7, is critical time when the onset of obesity is likely to persist into the adult years. That is why it is so important to teach healthy eating habits and good nutrition when we're looking at the younger age groups, the toddlers, the preschoolers. If we teach them good eating habits before they reach this milestone period or this critical period of 5 to 7, we can get a hold of obesity. You do want to look at the nutritional needs of the school age child, which can be found in your text on page 339, table 11-2. When we look at sleep and rest is essential for optimal growth and development. However, by the time children reach school age, most do not need a nap. Hopefully they do not need a nap. But I must say, I needed a nap when I was school age and even adolescence. I think I came home and took a nap. So you do want to note that all are different and some may still require a nap, but most do not. Although nighttime sleep habits may vary at 6 years of age, children require at least 10 hours of sleep, and at 12 years of age, they require only 8 to 9 hours of sleep. Of course, sleep is essential during the school age years to foster physical growth and academic performance, and failure to receive adequate sleep and rest can lead to irritability and lack of attention span at school, which then may lead to falling asleep and potential failing grades. Parasomnias such as nightmares, night terrors, and sleepwalking usually begin between ages 3 and 8. Some children will also have sleepwalking episodes, and this usually occurs in about 15% of all school-age children and is common between the ages of 4 and 8. Most children do outgrow sleepwalking by their adolescence. Safety is a priority, like I spoke on before, and should include locking outside doors and placing a bell on the child's bedroom door to alert the caregivers if they do wake up at night and get out of the bed. Sleep talking is also an occurrence that can happen during school age years, and this can occur at any age across the lifespan and does not indicate any kind of health concern or need for further investigation. When we look at their dental health, we want to know that during the school age years, the 20 deciduous teeth or baby teeth are shed and the permanent teeth do appear. This process usually starts at around 5 years old and is complete before adolescence, except for the third molars, which are your wisdom teeth. Those usually come in late adolescence or young adulthood. When children start to lose their teeth, the rate of loss is determined by genetics and, of course, gender. It is common for girls to lose their teeth earlier than boys. When looking at safety and injury prevention, the leading cause of death in this age group is accidents. So health education is, of course, focused on accident prevention. Most childhood accidents are related to motor vehicles, either as a passenger or as a pedestrian. Each year, 900 child pedestrians are killed and 51,000 are injured. Rules related to motor vehicle safety, bike and skateboard safety, swimming safety, and avoidance of firearms and strangers are critical during this period. Alright, health screening. Of course, each age group needs health screening. The school age is no different. When the school-age child is usually sick, it is typically a minor illness. Like I stated before, they're usually healthy during these years. The school-age child's average health visits are about 2 each year. The AAP, or American Academy of Pediatrics, recommends routine medical exams for the school-age child at least every 2 years and suggests they occur at ages 5, 6, 8, 10, 11, and 12. These exams should include height, weight, vital signs, a physical head to toe, vision and hearing screening, and assessment of dietary intake, use of tobacco, alcohol, and or drugs. You also want to know that an annual tuberculosis test is recommended for any high-risk children, especially if they had a positive test prior. When we look at immunizations really quickly, like I said, I won't make you remember or try to memorize this scale or the chart, but you do want to make sure that you are educating the parents on this chart. And usually we give the chart or scale to the parents so that they know and are aware of what the child will be getting at what age. Usually it begins in kindergarten and it will go through, young adulthood. And even then we still require titers. So for the school age child, they will get booster shots for their diphtheria, tetanus, and pertussis, measles, mumps, and rubella. Those are recommended between the ages of 4 and 6. And that's all I will say about immunizations. You won't have to remember what they're getting, why they're getting them, at what age, because that in itself can be a whole 16 weeks trying to understand that. If you are going to work as a pediatric nurse, you will get to know at what age they take which immunizations. And I can tell you firsthand, I have been a pediatric nurse for the last 10 years, and I still do not know them off the top of my head at what age. So do not even fret about trying to remember them. The doctor's offices and all of the hospitals are equipped with the American Academy of Pediatric guidelines for immunizations. The main thing here is that you do want to educate the parents or caregivers about the schedule and to make sure that they are staying abreast of, or shall I say, up to date on what they need to get for the child at certain ages. Alright, let's look at school for the school-age child. Of course, they should be in school at this time. And you want to know that school is an exciting new world because it provides the arena for physical, intellectual, and social development for this age group. School-age children who feel their school is a caring environment and have caring relationships are less likely to miss school or drop out. You want to also note that the teachers serve as role models. They strive to stimulate intellectual development, are in a position to influence the child's attitudes and values, and can be an important factor in determining school success. Nurses can also use cooperative learning as an effective method of teaching the school-age child in the healthcare setting. Now, you do want to note that if the school-age child fears school and they think that it is not a caring environment, they will not want to go. They will sometimes refuse to go. They will also try to be sick or pretend they're sick or complain of stomach aches, headaches, cramps, nausea, vomiting, things like that. I'm sure you've seen and watched enough TV where you can tell if the child is lying. And so we need to educate the parents that sometimes the child may have a phobia of going to school. What the parents need to do, we need to insist that the child return to school if they are refusing to go. Now, the parents may be a little naive and feed into this the first few times. I would say the first couple of days maybe. But after 2 days, the child either needs to be taken into the pediatric office, or the mom or dad or caregiver needs to investigate why the child is refusing to go to school. If any major illness is ruled out and the child is free of any illness or communicable disease, then the parents or caregivers need to insist that the child returns to school. If the child also has a phobia, you as the school nurse or the pediatric nurse, there may be a problem with both the parent and the child. So you want to investigate this further. And of course, you can come up with nursing diagnosis, such as compromised parental coping related to the inability to enforce school attendance. This would be a good one for those that do not force this child to go to school, even if they know or 99% think that the child is okay. So, as the school nurse or the pediatric nurse, we need to both investigate and educate the parents and see what's going on there. Alright, when we look at play, Piaget described play during the school age years as games with rules, as the child is able to think more objectively, thus making group activities a possibility. Socially, the school age child is beginning to understand the concept of cooperation and reflect this in their play as they work together for the good of their team. Play also provides the opportunity to learn what the body is physically capable of as growth and fine motor development are stimulated. By the time the school-age child is 6 years of age, the physical strength and stamina for sports teams have developed, contributing to physical health and release of frustrations. Lastly, since school-age children use play as an outlet to express their emotions, caregivers should participate in play with their children as a means of developing a stronger emotional connection. And an example of this would be if the child plays softball on their team at school, you as the parent or caregiver can then play it with them at home and practice with them, practice their technique, give them any kind of insight that you may have. If the child plays tennis, you can do the same thing on the weekends. Y'all can go play as mother and daughter or as son and father. Either one of those will foster a stronger emotional connection. Also, when we look at play, of course, the school-age child will enjoy these type of activities, and it is not limited to sports. They may also enjoy making things. So they may enjoy painting pictures in an art corner or crafting projects of some sort. So it is not just limited to sports. You want to know that the school-age child will also be into crafting and making things of that nature. So they may like art class. They may like painting. They may like painting on the weekends. So you do want to note that. And as the parent or guardian, you can educate them that they can still foster this emotional connection by doing these activities with the kid. So even if it's painting for 30-45 minutes on a Saturday morning after breakfast, this will foster that emotional connection. Of course, when we're looking at physical activity, it is associated with psychological benefits such as more positive self-concept and self-esteem, along with a decreased incidence of depression and anxiety. When we look at sports, however, you want to note that the child's muscles and bones are easily injured because of immaturity. So athletic activities must be carefully selected according to the child's physical development and not the caregiver's wishes. And when they say this, they really want to stress that the parents aren't putting the child in ballet or opera or piano or football or basketball because they didn't get to do it, or that was a passion of theirs when they were children and either something happened, they broke a leg or something like that, and they're now making the child do it and they're living vicariously through them. That is not what we want when we send our children off to play these sports. You want to also note that the sports most likely associated with injury for the school-age child include baseball, football, and soccer. As the child seeks cooperative play with rules, team sports become very interesting to them. Team play can also contribute to physical and social development as the youngsters learn to play as a team member and work for common goals. However, during the school age years, the child is also exposed to the high value placed on winning and competing and should learn healthy balance between playing for the sake of playing and always winning and competing. This is also important, especially if you have the child in that sport for your sake or the parent's sake. You're going to always be so fixated on them winning or competing to win. The child needs to be able to actually enjoy the sport and have a healthy balance between enjoying to play the sport just for leisure and then winning and competing with that same sport. When we look at peers, as the school-age child becomes older, they'll gain more independence and spend more time with peers of the same gender. Friendships develop that may influence them for the rest of their lives. Peers help each other learn about the world and all its possibilities, influence self-esteem and self-confidence, and are important sounding boards for issues needing to be discussed. When we look at the body image, this is important during school age, but it becomes even more important once we get to adolescence. School age children are knowledgeable about their bodies and will often compare how they look to how their peers or adults look. Children also are acutely aware of physical differences related to height or weight, and know if they are not as coordinated as their friends. If the child has a physical disability, it is not uncommon for other children to call attention to the disability, exclude them from activities, and at the same time worry that they themselves will have a similar disability. So this is one of the things that they really worry about when it comes to body image. And so we need to educate both the parents and the caregivers about disabilities and making sure that the child is confident when they go to school. Next, we will look at bullying. Developing social skills is one of the primary tasks of the school age years. For children who lack such skills, one of the ways to express their anger is an act of bullying, inflicting verbal or physical harm on another. Boys are more likely to engage in bullying than girls and to use physical intimidation. Children who bully try to control or dominate others and have often been bullied themselves. Bullying is more intense in middle school and declines once in high school. Children with emotional or physical disabilities are often bullied more. Signs of bullying can include physical scratches and bruisings, requests for extra money for school, and the resistance to attend school. The effects of bullying may negatively impact school performance, decrease self-esteem, and increase anxiety. If bullying continues, the victim may become depressed, withdrawn, and even suicidal. School nurses can play a vital role in identifying both the victims and perpetrators of bullying behavior and must take action for the safety and well-being of all involved, as some of the recent incidences of school violence and shootings were carried out by students who were bullied by their peers. Taking action includes notification of the school principal, teaching staff, and caregivers of the involved children, plus taking the lead in the development and delivery of an anti-violence system. And I know you guys remember, it has not been too long ago that some of these students were bullied on Facebook, and therefore they committed suicide. They jumped off buildings. So bullying is a serious offense now, and not really sure what they did to persecute the person that was actually doing the bullying, but we do want to take account of that and educate both the parents and the child about the effects of bullying and how it can ultimately affect their development and how they perform in school. This may also be another time that the child may not want to go to school, so we do want to investigate this as the pediatric nurse or even as the school nurse. You want to educate the caregivers to investigate this as well. So we do want to promote positive self-esteem, and as the parents or caregivers, we do want to educate them that they need to be coaches or cheerleaders for the child, as this can foster good self-esteem and allow the child to be confident no matter if they have a disability or any chronic disorder. Okay, so that is one of the major things that we do stress, whether it be in school or in the pediatric office, is the effects of bullying and how the parents can help the child and how the child can actually help themselves. Alright, let's talk about the essentials of the school-age child. We're going to continue on with stress, and that starts on page 346 in your text. And if you look at those following four examples right underneath the column that says stress, your book wants to explain that if you really did not know the child or the pediatric client, or if it was not your child, how exactly would you know if they endued any stress, whether it be their procedure or school-wise, or with the family member being diagnosed with something like cancer? How would we as pediatric nurses know that the child is stressed or is having a stressful situation occur? A situation is considered stressful for a child when there is a discrepancy between demands placed on the child and the child's perceived ability to make these demands. In addition, what is stressful for one school-age child may not be stressful for another. If the child feels resources and supports are available, it may be viewed as a positive challenge instead of a negative threat. Therefore, school children need to be prepared at least a week in advance of a stressful event such as surgery, so they can have their questions answered and formulate coping strategies. So you may see an example such as, when would you prepare the pediatric school age client for a tonsillectomy? Well, your text says you need to prepare them at least a week in advance. Now, that does not mean you have to prepare them exactly 7 days, but make sure it's at least a week. Don't prepare them like 2 days before they're going for surgery. That won't work. This will cause stress, trust me. Also, you want to look at the pediatric clients that have difficult temperaments. I know we talked a little bit about the temperament issue back when we spoke on the preschooler or even the toddler. Some kids have different temperaments. Those with difficult temperaments, this may cause stress in the family and with the parents or caregivers. Parents do need to stay objective in emotional situations, and they also need to learn how to deal with high-risk situations, as the child may be very difficult to live with if the family does not remain neutral or objective. So you want to make sure as the pediatric nurse or even as the school nurse that we're educating the parents or caregivers about the temperament of the child, because this can be a stressful situation not only for the child but for the parents or caregivers as well. When we look and talk a little bit about latchkey children, today, in both single and two caregiver families, more caregivers are working outside of the home. It's not like it was a long ago where we had so many stay-at-home moms. It is estimated that parents of more than 28 million school-age children work outside the home. So, as a result, many children come home after school to an empty house, and they are alone for a period of time without adult supervision. That is the actual definition of a latchkey child. If they're coming home and there's no one home, that means no one. The the dad, the mom, the sister, the brother, there's no one home, and they're left in the house to fend for themselves, basically, for an amount of time before an adult arrives. The hours between 3 p.m. and 6 p.m. are peak times for juvenile crime and experimentation with sex, smoking, and drinking alcohol. Why is this? Probably because there's no adult supervision. So, it's not to say that your school age child that's, 8 needs an adult there, but they should have someone older than them available in the house. Or they need to go, it's not uncommon to still go stay with the neighbor or, go to a family member's house until the adult can get home because, of course, they're out of the house working. Unfortunately, there is a chronic shortage of after school programs in the U.S. Although 76% of Americans agree that Congress, state, and local officials should increase funding for such programs. I also agree with this because then we won't have as many 8, 9, 10, and 11-year-olds that are coming in pregnant. So, that's a thing to think about. I also do want to go back to stress for a few minutes and just want you to look at that table in your text on page 346, table 11-3. Those are some common signs and symptoms that you can educate the parent or caregiver that they can look for in the school-age child. Signs of those stressful situations: fatigue, irritability, of course, anxiety, maybe low self-esteem, and a change in their sleep pattern are among the most common. As pediatric nurses, we have the responsibility to recognize common manifestations of stress and must work in partnership with the child and the family to determine effective methods of stress reduction. Since the school-age child often enjoys writing, they can be encouraged to write about their experiences in order to cope. Sometimes we will recommend journaling for this child if they are having stress of any kind. Additional stress reducing techniques such as relaxation, guided imagery, or distraction can also help the child. When we look at honesty, it is not uncommon for the school-age child to steal, cheat, or lie. Although these behaviors may be upsetting for the caregivers, they are often just a phase that the child goes through and may be related to immature cognitive development. On the other hand, it may indicate a more serious problem. Young children may steal because they want something another person has, feel they were treated unfairly and want revenge, or they may want to be bribed other children. So, as the school nurse or the pediatric nurse, we need to take account for that, and you need to be aware and educate the children and make sure that they know that stealing is wrong, but it is common at this age. One key thing we do want to do is make sure we teach the family about tips on honesty. You want to make sure that the paramedics, the parents or caregivers are role models showing the behavior that they want the child to exhibit. They want the child to be honest and respectful to others, then they need to do so also. They want to try to understand the motive behind the child's lying. If the child is lying all the time, what is their motive? Discuss the consequences of lying without being angry, of course. The parents can't be so judgmental and rigid because then what's going to happen with the child? 9 times out of 10, they're just going to shut down and not talk to anyone. Or where will they run first? To their peers, which we all know they don't usually give the correct information. And of course, you want to reinforce the benefits of being honest. So those are key tips that you do want to talk to the parents and educate them on as far as communicating with their kids when it comes to being honest. When it comes to limit setting and discipline, Nutrient caregivers include discipline in a warm, supportive, and empathetic relationship with their school-aged child. In effect, caregivers who model responsible behavior can easily be examples of effective values. Implicit in discipline approaches is a fundamental attitude toward the child. Taking the child seriously and treating the child as a person whose feelings and questions matter is very critical. The child's preference, however, cannot always be accommodated, but should be considered and never dismissed. Reasoning capabilities of the school-aged child are being developed, so talking about and explaining a negative behavior and clear understanding of consequences should be encouraged. Withdrawing privileges is often a satisfying method of discipline. Now, with that said, withdrawing of privileges, when you think about the school-aged child, what privileges do you think will be, will be appropriate to withdraw when you're looking at disciplining the child? What you have to think, what does the school age child like? Now these age groups, they're involved in sports, crafts, things of that nature. And now today and age, everybody has a phone, a computer, or a laptop, or iPad, iPods. So you can withdraw those privileges. Those would be some good privileges to withdraw, and this will probably 9 times out of 10 make the child straighten up. You don't want to do it out of anger. You want to teach the caregivers not to do it out of anger, but that they do need to teach the child a lesson. So maybe they can tell the child, 8-year-old, that they can't go to the soccer game on Friday, or tell the 11-year-old that they can't have their iPad and their iPod and their phone for a week, depending on what type of punishment they are looking at getting, or what type of discipline they're looking at. Depends on what they actually did to earn some type of limiting or disciplinary action. So you do want to teach the caregivers about that. They have to be aware of what the kid actually likes or what the kid is actually involved in before they enforce some type of punishment or discipline. When we look at sexuality, school-age children may engage in some form of sex play during the late school years. This is normal behavior. Caregivers should avoid drawing attention to it or laying on guilt. At a very early age, children are exposed to sexually explicit information through, of course, media. Unless caregivers are honest and open about sexual issues, children will seek answers to all of their questions, trust me, from their peers. All too often, the information from the peers is what? Inaccurate. Therefore, it is imperative nurses be available to provide education regarding sexuality to children and their caregivers. So, with that being said, of course, these children are becoming sexually active, and they have all of these thoughts and perceptions about how great it is, or my friend is doing it, so I'm going to try it too, or they get talked into it. There comes the peer pressure, and it really gets laid on thick when they get into the adolescent stage. But as you can see, it starts early, and that's why we have sexual education so early in school now, because we are seeing the 8, the 9, the 10-year-olds coming in pregnant. That's crazy. So I think with the correct information and knowledge, then the child will most likely, well, I can't say most likely. We hope as healthcare providers that the child will make the right decision. But you still have to take into account, family dynamics, what's being taught in the home. Is the home dysfunctional? Are the parents setting good examples? And things of that nature. So those are all things you have to take into account when you look at sexuality. But as the nurse, we can be available. Our role will always be as the patient advocate and as an educator, okay? So, the nurse's role in fostering healthy school-age children. How successful the child feels during this period can shape his or her future success in work and relationships. As the nurse caring for the school age child, it is an ideal position to serve as a positive role model and teacher for both the child and the caregiver. Education about nutrition, exercise, rest, sexuality, and safety can foster healthy habits throughout the lifespan. And that will actually conclude chapter 11, which goes over the growth and development of the school age child. Stay tuned as we will go into chapter 12, which reviews the growth and development of the adolescent. Alright, welcome to adolescence. This will be the last chapter, which we will talk about growth and development, which I am sure that you all are quite excited about. So let's get started. Between childhood and adulthood, individuals experience the unique developmental period known as adolescence. This includes ages 12 to 21, when young people begin to focus on who they are, how they are similar to or different from those around them, and what they want to become when they reach adulthood. It is a time of exploration, excitement, and sometimes confusion and despair. Adolescence is second only to infancy in the amount of change individuals encounter physiologically and psychosocially. The concept of an adolescent stage of development is actually a relatively recent phenomenon. Not until the beginning of the 20th century did society begin to recognize adolescence as a unique period of development different from both childhood and adulthood. Adolescence does consist of early, middle, and late periods. Each is distinguished by several different aspects of adolescents' lives and constitutes the ages 12 to 14, 15 to 17, and then 18 to 21. Another way to differentiate these periods relates to the physiological development. The first one is prepubertal, which is early adolescence, pubertal, which is middle adolescence, and postpubertal, which is late adolescence. A third way relates to the level of education. Early, middle, and late adolescence are associated with middle school, high school, and then post high school. So you can break those down, and an easy way to remember it is early as 12 to 14, and they're usually in middle school. 15 to 17, they're usually in the middle, and this is usually in high school. And then 18 to 21 is usually post high school or late adolescence when they're going off into college. When we look at physiological development, puberty is a state of physical development between the ages of 12 and 16 for females and 12 and 16 for males and 10 and 14 for females. When secondary sex characteristics begin to appear, increased body hair, growth of the breast in females, increased muscle mass, voice changes in males, widening of the hips for the females, and changes in body fat distribution. Sexual organs mature, reproduction first becomes possible, and the adolescent growth spurt starts. Adolescence begins with puberty and ends with an individual when the individual is physically or psychologically mature and able to assume adult responsibilities. The age when puberty begins and how long adolescence lasts varies individually and cross-culturally. So, when you're looking at distinguishing between the early, middle, and late adolescence, you do want to know that these vary. Of course, Every adolescent is unique, so we can't group them all together and say that they're all going to hit puberty at, you know, 11, when we have some females hitting puberty at 8, as well as some not hitting it until 14 and a half. So it just really depends on the individual and their culture. And sometimes we can even look at genetics and see, when the parent or caregiver started to develop or first got their menstrual cycle or things like that. As for the males, you may have one getting chest hair and body hair at 11 or 12, whereas another may not get this until they're 15 and a half. So we do want to note the differences and not group everybody in that same category. When we're looking at the musculoskeletal system, during the adolescent growth spurt, known as AGS, it lasts about 4.5 years. The body assumes an adult appearance. Girls may begin their spurt as early as 7.5 or as late as 12 years of age, whereas the boys typically begin their growth spurt by age 13. Now, what I do want to make note of is that you do not get puberty confused with the growth spurt. The growth spurt does not signify puberty. Puberty is defined as when they are getting those sexual characteristics and they are able to actually reproduce. Okay? So just because the child has a rapid growth spurt does not necessarily mean they're hitting puberty. That is just one of the aspects that happens to occur during the adolescent period. Okay? So do not get those confused. During the adolescent growth spurt, there is a rapid acceleration in weight and height. Boys gain about 12 to 14 pounds and grow about 3 to 6 inches, whereas the girl gain about 8 to 10 pounds and grow about 2.5 to 5 inches. Full bone length is first reached in the extremities and move inward. Trunk growth begins with lengthening and widening of the hips, especially in the females, and then involves broadening of the chest and shoulders, especially in the males. Males have a greater arm and leg length relative to trunk size and delayed skeletal ossification as compared to females. Sebaceous glands increase in size as they become active for both genders. Eccrine and apocrine glands mature as well, leading to increased amounts of and a distinct odor to perspiration. Perspiration is also now secreted in response to emotional stimuli. The skin becomes darker and the texture thickens and toughens in the males. Females, however, develop soft, smooth textured skin with fine hair growing on the cheeks and upper lip, which we all hate. So that's why whoever invented waxing and tweezing and facial cream removers, we love them. Okay? The first visible sign of female sexual maturity, and this is talking about the GU system, is breast development, which may not be symmetrical, and I will talk about that in a minute. This is followed by the pubic hair, which begins on average between 11 and 12 years of age and is complete about age 14. This is, again, you want to note that each child is unique. So if you have a 7-year-old coming in with pubic hair, do not freak out. As the pediatric nurse, we have to understand that your text is telling you an average, but as we know, in reality, this is happening earlier and earlier. So we want to be aware when we are doing a physical exam, especially our GU portion on our adolescent children. In the females, menarche, or the first menstrual period, indicates puberty and sexual maturity. Most adolescent females are ambivalent about menarche. They are happy for the proof they are women, yet view it as a burden since they are unable to control their bodies. Usually this is when PMS comes around. So, even though regular menstrual cycles and ovulation typically begin 6 to 14 months after the first period, or adolescent females can become pregnant after their first menstrual period. Menarche occurs about 2 years after breast development starts and after the growth spurt peaks. Heavier children of both genders begin puberty earlier. So that is another thing you want to know, especially with a lot of the obese children that we are now seeing. Whereas those adolescents who exercise excessively or are underweight may have delayed or arrested pubertal development. Males' puberty and sexual maturity are initially indicated by growth of the penis and testes, spermatogenesis, and seminal emissions. Now, I want to talk a little bit about the breast size. You want to note that the child may have asymmetrical breast. This is normal. You want to make sure you're educating the adolescent that this is normal because they will come into the office freaking out. So, you want they'll want to know if there is something wrong. There's usually nothing wrong, but of course you do want to make sure you educate them on doing their self-breast examinations and what they should be feeling for. It is important because they are often the first ones that can tell if they have a lump of some sort, and we would like to diagnose or treat the lump or cancer early if that is what is found. When we look at the cardiorespiratory system, the heart almost doubles in weight and increases in size by about one half during adolescence. Although the heart continues to enlarge until the age of 17 or 18, the rate of growth is slower in comparison with other body systems, and the pumping mechanism is somewhat inefficient. This may cause one to be fatigued, symptoms of inadequate oxygenation, and some adolescents will complain about this. The average blood pressure is about 100 to 120 over 50 to 70. The pulse drops from the childhood rates to an average of about 60 to 70 because if you will notice, we've gone all the way from the infant that could reach up to 160, now down when we get to adolescence, they're now more in the adult ranges of 60 to 70. The lungs increase in length and diameter during the adolescence, and the respiratory rate averages about 16 to 20 per minute. The slowness of respiratory system growth relative to the growth of the other body systems may cause the inadequate oxygenation and fatigue that is sometimes experienced by the adolescent. So they may complain that they are tired all the time, or they shouldn't really have any trouble breathing, but they may complain that they get out of breath faster, and this is the reason why. When we're looking at the neurological system, the prefrontal cortex, which is responsible for executive functions such as self-control, judgment, and emotional regulation, organization, and planning, this undergoes significant change between puberty and adulthood. This has been interpreted to mean adolescents may respond with gut reactions to emotional stimuli, while adults are more likely to respond in a more logical manner. As far as the GI system or gastrointestinal system, rapid maturation of the GI system occurs during adolescence, and by the 21st birthday, all 32 teeth should have erupted. Gastric acidity and capacity increase up to 1,500 milliliters to accommodate and facilitate digestion of increased food intake that occurs in the rapid response to growth. Adult size, function, and location of the liver is attained, as are adult elimination patterns. They shouldn't still have enuresis and things of that nature. If so, there is a problem there. Looking at self-understanding, two major tasks of adolescents are figuring out who they are and what their unique place in the world is. So, the adolescent faces many different decisions during the teen years concerning the future and the adult world. So, this is one thing that, as the pediatric nurse, you want to talk to them about. Some have argued the need to define oneself as a function of heredity. Others contend it is a function of hormonal changes that emerge during adolescence, while others believe it is a response to changes in adolescent interactions with those in their social context. So, like I said, when we're looking at more of the psychosocial development, the main key that you want to take from that is that when you go to assess this adolescent child, first of all, these are the age groups that will probably want to be assessed by themselves. They will not want the parent there. So you are to provide for them. Talk to them face to face directly. Of course, still talk to them in terms that they can understand. And since they're faced with so many decisions during these years, they're concerned more about their futures, the adult world, and I can really say that this applies all throughout adolescence. Of course, it may apply more to your late adolescence when they're getting ready to graduate and go into, the adult world setting. But they may start thinking about, the future and the adult world as early as 11 or 12, okay? As soon as they hit adolescence, these are things that we now educate them to think of. You cannot wait until you're 21 and now all of a sudden you're an adult and you don't know what to do. So during the adolescent stages, we are concerned that they are focused on the future and the adult world. So we want to engage in open-ended questions, especially when we're going through assessment. This is a type of therapeutic communication for this type of child, at this age group, that is. All right, looking at the psychosexual development. Who is this again? Good old Freud. When Freud talks about psychosexual theory for adolescents, one compels us to appease our inherent biological drives, while the other fosters the desire to live in a social community. Freud contended that virtually all psychological development is an adaptive response to an upsurge in our physiological base drives and our attempts to satisfy these drives while coexisting with others. To effectively cope, adolescents need to redirect these newly re-emerging energies from parental relationships to non-familiar relationships, which are the friendships and the love interests and career endeavors. For this to occur, a separation or detachment from the parents is necessary, sometimes resulting in conflict between the adolescents and their parents. So, what this is really saying is that the teen is really becoming more independent and they're looking for their way in life, okay? So they're going to become independent from the parent. We could see that they are already engaging with peers, but within the adolescent period, their peers have such an influence on their lives. It's crazy how much influential difference it makes on the adolescent's outlook on life. Of course, the parents are still there. We still need them to nurture them. We still need them to educate. We still need them to discipline accordingly. But most of their time will be spent with peers. Most of their advice will come from peers or their relationships and things like that. And they will start looking for, a career. They're focused on the future and career development and the adult world at this point. As for the body image, of course, this encompasses positive and negative feelings and the self-perception of physical attractiveness. Implicit in the definition is the assumption that one's body image varies with maturation and changes across time. situations, and experiences one has with others. Constant changes in appearance, including increases in weight and height, appearance of body hair, oversized hands and feet, developing sex organs and facial blemishes, presence present the adolescent with new challenges, both real and imagined, that affect his or her body image. While developing a sense of body image, most adolescents look to this cultural idea valued by their society, which is not good most of the time. More than vanity, the adolescent's preoccupation with appearance is recognition of the role physical attractiveness plays in gaining the attention and admiration of the opposite sex. So basically, what this is saying is that, of course, the teen is going to want to look like the typical model type. Some go to the extreme, and that's when we go into, the anorexics, the bulimics, and things like that, because they're trying to be a size -0, and it just does not work, okay? So I think TV and media has been doing a little better when it comes to advertising, the ideal weight and height and how you should look. We know everybody's not going to look like they stepped out of a magazine and they're going to Hollywood, on the red carpet. But still, teens are very influenced by what they see and, of course, their peers if they want to fit in. This is another issue that may come up. They're trying to fit into society. And of course, then we have the almighty trying to impress that one of the opposite sex. Of course, if they are interested, whether it be boy or girl, in someone of the opposite sex, and that person is not interested in them, yet they see what type of female or male that they are interested in, they will then seek out that person and attempt to be like that person, do what that person does, in an effort to get the attention of the person that they are liking. You want to note that many factors influence body image, including present and past experiences, level of cognitive development, and of course, identity formation. The young people who have the most difficult time adjusting to their physical development and body images are those whose bodies is on a different schedule than that of their peers. Although some findings suggest early maturation for girls is associated with high social status and prestige in the peer group, most findings indicate early maturation is associated with greater vulnerability to social pressures, leading to problems in social adjustment, which may often persist into adulthood. Early maturing females may be socially disadvantaged because they are out of step with their other peer group. They may become lonely and experience pressure to become involved in sexual relationships beyond the level of their maturity and coping ability. This can result in damaged self-esteem. Often those who are taller and more developed early on relative to their classmates discover there are few peers who share common interests or problems. As a result, they often attract attention of older boys, resulting in their heightened risk for engaging in delinquent behavior and greater vulnerability to eating disorders, depression, and deviant peer pressures as compared to that of a late maturing or on time female or male. As for your later maturing males, they tend to be less relaxed, poised, and popular with peers, and feel more restless, talkative, and socially inadequate and inferior. So, for your females, of course, if they are developing at an early age, like we said, 8, 9, 10, within your school age, if they're that developed, as you can see when we get into the adolescent stage, they're now way beyond their peers that are just going into, this type of development, if they're developing, later at 14, whereas this female, will give her a name, we'll call her Lucy. If she developed while she was 8, but her friends didn't develop till they were 13, she may then attract the attention of a 15-year-old, you know, while she's 8, and therefore we have the pregnancy. So as you can see, it kind of builds upon each other, these stages of development, and now I hope that you're able to kind of fit the puzzle pieces together as to what's actually happening with each stage and how they connect to each other to form the bigger picture, or actually lead them into adulthood. When we look at the psychosocial development, we first want to look at the psychosocial identity. So, the major task of adolescence is, of course, establishing a personal sense of identity. Adolescents define themselves according to several distinct physiological, psychological, and social events and experiences. Those are listed in your text on page 367. They're numbered 1 through 6. The adolescent sense of identity is based on 3 primary factors, one being individual identification, such as the parents, peers, teachers, or folk heroes, as well as group ones, my group of friends, our generation, other blacks, other Americans, established during childhood. 2, the ability to master each developmental task, such as trust versus mistrust, autonomy versus shame and doubt, presented to them by the society. And 3rd, the establishment of their own ideology based on the social, political, and religious attitudes and values that they adopt. As for the identity statuses, not all individuals arrive at a definitive answer about who they are during adolescence. Many will spend much of their lives either avoiding or failing to see a need for establishing a sense of identity. Although many young people won't establish their identity until young adulthood, the process generally begins during adolescence. And you can probably see this firsthand, how some young adults, or even by middle adulthood, they still have no sense of identity. So you can see some of the factors that tie in that help them form this sense of identity. And if they fail, they're just like stuck in this one phase. So, with that being said, we will look at cognitive reasoning and personal identity. An important part of adolescents' ability to develop personal identity is their capacity to think in more complex and abstract ways, allowing them to consider the more psychological characteristics that define them. As adolescents initially begin to think in increasingly complex ways, they begin to demonstrate increased levels of differentiation in how they define themselves. When we look at gender identity, this refers to the way that we think ourselves as either female or male, and in combination of biological makeup, personal and social expectations, recommendations about how males and females should think and behave. Lastly, identity and intimacy. Erickson contends once young people have achieved a sense of who they are better able to commit themselves intimately to another person. According to Erickson, the youth who is not sure of his or her identity shies away from interpersonal intimacy or throws himself or herself into the acts of intimacy which are promiscuous. Such an individual may be involved in intimate relationships, but is likely to settle for highly stereotyped interpersonal relations, resulting in a lack of fulfillment and a deep sense of isolation. So, you want to actually strive to achieve these milestones in development so that by the time you get to young adulthood, you're not stuck or you're not feeling isolated. And one thing that I do want to point out is with the attitudes of an adolescent. Of course, they're going to be all over the place, okay? They may be happy one day, they may be moody the next day, they may be quiet one day. We want to educate the parents and the caregivers that they need to sit down and talk openly with their children, no matter if they're an adolescent or not. Because if not, what will happen? They will have the peer influence, which we all know that can go down the drain really fast. So if you have a moody 14-year-old who shuts themselves in the room a lot, or they fight with their siblings, you want to educate the parents that they need to talk calmly to him or her about their concerns and see what's actually going on. Most of the time, parents get frustrated or they're angry and they punish the child without even finding out what's going on. So this is part of their actual development. So you want to actually look at what is going on and talk with the child. And even if the parents or caregivers aren't talking with the child, you as the pediatric nurse should be able to talk calmly with him or her and figure out what's going on. You want to ask open-ended questions, and we'll talk more about communication with the different age groups, but most of the time you want to have an open-ended question for the teen to actually open up and explain what's going on. Most of the time it may be school related, it may be peer related, it may be something to do with relationships. You never know. So you have to be non-judgmental as well. Moving on to cognitive development of the adolescent, we look at Piaget's theory again, and one outcome of the adolescent's ability to consider abstract possibilities is that they begin to recognize the distinction between how things are and how things could be, which is the difference between the real and the actual ideal. During the early stages of development, the real and the ideal are largely the same. However, as adolescents' thinking abilities moves beyond the limitations of reality, they begin to conceive of the possible. Another significant cognitive change is language development. Compared to children, adolescents are generally more sophisticated in their ability to understand words and their related abstract concepts. As adolescents become more cognitively mature, they are better able to adjust their thinking strategies to fit new information now available to them. Looking at adolescent egocentrism, formal operational thought enables adolescents to think about their own thoughts and also permits them to realize that other people's thoughts are separate and distinct from their own. This capacity to consider other people's thoughts is the crux of adolescent egocentrism. When one is unable to appropriately differentiate between oneself and the objects of one's attention. Although some egocentrism is present at each stage of development, it is mostly commonly associated with the adolescent's thinking. With the onset of formal operational thought, adolescents are now able to consider the thoughts of others. Although adolescents realize others' thoughts are not the same as their own, they have the mistaken notion that others know what they are thinking and assume others are as obsessed with the adolescent's behavior and appearance as they are themselves, resulting in an even greater sense of self-consciousness. So they think that everybody thinks just like them, and that everybody is obsessed about how they look, when this is certainly not the case. So when we're teaching families and caregivers about cognitive development of the adolescents, you want to let them know that they're likely to begin questioning many things previously learned, and they are capable of reasoning problems out for themselves. Adolescents will often begin re-examining many parental rules, values, and explanations. They need opportunities to explore the reasons for different religious and political views, attitudes about sexuality and social responsibility, or explanations about injustices that they see. They need clear explanations of values and the reasoning behind them also. They will also need others to demonstrate greater willingness to listen to and understand adolescents' evolving opinions. When we look at social perspective taking, another important aspect of adolescence cognitive development. Sorry for the brief interruption, that was my computer talking to me. So, as I was saying, looking at the social perspective taking, another important aspect of adolescent cognitive development is their broadening ability to assume another person's perspective. Early adolescence, initial attempts to focus on the relationship between self and others is particularly evident in their best friendships, where there is a high expectation regarding uniformity in dress, interests, and activities, and individual differences are considered threats to the relationship. Moral development, an important aspect of young people's cognitive maturation, is their ever-increasing ability to consider the complexity of their own and others' moral and ethical reasoning. The concern for moral values and standards is likely to never be more relevant during adolescent time. In addition, parental discipline, and more specifically, the discipline techniques applied, is also crucial in determining whether a response to a moral situation will be internalized. The ability to consider the moral implications of their own and others' thoughts and actions is crucial to adolescents developing a personal belief system which largely defines their social, political, and religious identities. Lastly, when we look at religiosity, for many adolescents, an important part of their moral development is the formation of their own religious beliefs and personal patterns of religiosity. Religion appears to have positive implications for adolescents with greater religiosity, demonstrating an inverse association with risk-taking behavior and a positive one with greater social competency. Adolescents' religious involvement is both predicted by their social context and predictive of how much they contribute to their social context. Adolescents' church attendance continues to primarily be influenced by their parents, but is also predicted by the attendance patterns of their friends and, to a lesser extent, schoolmates. So, basically, it is what it says it is. An adolescent child or adolescent kid is more apt to go to church if the friends are there, or if they're excited about seeing their classmates versus their parents making them go. They're more excited during this time because they're seeing their peers. And like I said, you'll keep hearing this, that their peers during this time are so influential in almost everything that they do. Let's now take a look at the adolescents in context. First, we want to look at the families. The family is the first and, in general, the most important socializing agent in one's life. Successful socialization is the process by which children acquire the beliefs, values, and behavior deemed significant by older members of their society, and is, to a large degree, a function of the parenting and other familiar interactions experienced while growing up. Several changes are likely to have an impact on the type of interactions and quality of relationships adolescents and their caregivers have with one another. First, adolescents experience physiological changes associated with puberty that cause both and the caregivers to think and respond differently to one another. Caregivers begin to expect adolescents to act more like adults when this is sometimes not going to happen. And while they may not always act more mature, adolescents begin to believe they should be treated more like adults. Well, you cannot be treated like an adult if you do not act like an adult. So we do have to teach them that. These changes in adolescence interpersonal interactions with caregivers may be linked to the onset of puberty and the hormonal changes that occur during this period, resulting in greater conflict, particularly with when adolescents experience precocious or early pubertal development. Abstract thinking allows adolescents to better distinguish their real and ideal worlds, resulting in caregivers observe behavior, no longer defining adolescents' ideal standard, which is now measured according to what ideal caregivers should be like. If caregivers are not sensitive to adolescents' desires to test their newly found cognitive skills, adolescents are likely to be incorrectly perceived as defiant. In seeking their own identity, adolescents begin to explore the attitudes and values they have been taught in order to establish what best defines who they are. So the parents should be able to give them some leeway without being so rigid. So we do have to teach the parents and caregivers that they do need to allow the adolescent to basically find themselves and explore the adult world. When we look at parent socialization, the optimal situation for positive adolescent outcomes is when parents use a high amount of both responsiveness and demandingness. Adolescents are likely to face various struggles when either one or both of these elements is missing from the parenting experience. So you want to make sure that the parents and guardians have a balance. They have to, of course, be responsible, but they have to make sure that the adolescent is being responsible as well. You have to lead by example, of course. The parents should not be so demanding that the child will be defiant, but there has to be some type of discipline and limit setting when it comes to adolescents as well. They are involved in way more risky behaviors and things of that nature. So we have to make sure that we're educating the caregivers that there has to be a balance between the two. When we look at attachment and autonomy as young people approach adulthood, they want more autonomy and they need to have a sense of self-direction and independence. Caregivers, however, are often unsure of how to provide opportunities for establishing autonomy. They may even feel threatened by their child's desire for more independence, therefore responding by exerting ever-grading control. And this is not okay. They have to let the child explore. They have to give them some type of leeway. And I just spoke on this. The interesting dilemma for adolescents is that although they are attempting to establish a sense of autonomy and as a result often act as if they would rather die than being seen with their parents. The unsureness of this period makes the safety found in the caregiver-child relationship no less important. So during adolescence, I mean, they really are going to want to be with their peers. They're not going to be so much with the parents as they were, as a toddler, as a preschooler, as a school, even as a school age child. They tend to start being with the peers. So, what parents have to realize is that let them go with their friends. Just make sure that they understand, being safe and when to come home. Like I said, you will have to make sure you have a balance because these adolescents are going to want to explore. When we look at caregiver adolescent conflict, this is what happens when there is no balance. Conflicts between the parents and the adolescent occur because either parents want adolescents to follow directions or they want the adolescent to avoid making the same mistakes the parents did when they were adolescents. Sometimes this cannot happen. I don't care if you talk to them till they're blue in the face. Sometimes they are going to have to make their own mistakes in order to learn, in order to grow. So, although we stress this, let me teach you this, let me tell you this, listen to me because I know this is bad or I already been there, done that. Sometimes this does not matter. The adolescent child is stuck in their own ways. Although they may listen to some of what you say, trust me, their peers have like 85% more influence than you do as the parent or caregiver. So, as the pediatric nurse, you want to make sure you're educating these parents. They have to be patient, especially with an adolescent. It is just like we're going all the way back to toddlers when we're potty training. You cannot be over aggressive with these teenagers because then what are they going to do? Shut down completely and turn to their friends. So we don't want that to happen. The conflict may be related to generational differences in attitudes, beliefs, and values during a time of major transitions that is in and of itself stressful. In addition, many parents and adolescents do not process adequate communication or they do not possess adequate communication and coping skills to handle stress associated with these transitions. That's a whole nother problem in itself. If they don't know how to communicate from the get-go, of course they're not going to be able to sit down and have a normal conversation and actually talk about what needs to happen or their feelings, thoughts, beliefs, and things of that nature because it's dysfunctional. So that is another thing that, we as nurses have to work with both the parent and the adolescent. Conflict between adolescents and their parents is usually higher during early and middle adolescence. In addition, a couple of researchers found that most young, which are between the ages of 11 and 14, adolescent parent conflict tended to be negative, confrontational, or avoidant and reactive, whereas 10 years later, the conflict tended to be more direct, healthy, and less negative. Conflict between parents also affects the adults, and this means conflict between either the mom and the dad, or the dad and the uncle, or the two moms or two dads, or however that may go. If there's a conflict between the two adults, of course this is going to cause undue stress on the adolescent, and then therefore communication between the caregivers is then impaired for the adolescent, which moves us toward divorce and remarriage. Of course, young people who experience divorce as adolescents are more likely to have drug problems than adolescents whose parents divorced when they were children, or those who grew up living with two biological parents. When divorce occurs before adolescence, girls appear to particularly struggle as they approach adolescent dating experiences. They seek more attention and contact from male adult and peers and become sexually active earlier than girls whose fathers had either been present during childhood or whose father's absence was due to a death. Although numerous studies have demonstrated that adolescents of divorced parents tend to be more at risk for social emotional behavior and cognitive disturbances. So we want to make sure we are educating the parents and caregivers how a divorce actually affects the child. Same with remarriage. If there's conflict in the home, you cannot say that the adolescent is not involved. Even if it does not directly involve them, they are inadvertently involved. So we as nurses stress the education on these important essentials here. Looking at sibling relationships, siblings provide a unique relationships for adolescents because they're generally close in age and are likely to spend a great deal of time with one another. Interestingly, their relationship is one in which there is no choice about membership. Thus, while conflict in friendships may be avoided in order to preserve the relationships, sibling relationships have more warmth and conflict since they do not operate under the same threat of termination. You can't necessarily ban your sister or your brother. So they're going to be there in the same house with you. So that's why that conflict usually ceases to desist, or they get over it after a period of time. Often progression through adolescence was associated with a reduction in perceived sibling support and corresponding increase in perceived sibling conflict, which apexes between the ages of 12 and 13, followed by an increase in support and decrease in conflict when youth reaches about 15 or 16. Why do you think that is happening? Well, when the child is 12 to 13, they're just kind of coming into puberty, adolescence, they're trying to find their way, so of course they're going to have conflict. When they get about 15, 16, they're doing their own thing, they've got their group of friends, they may have a job, so then there's less conflict between the siblings, and it's more supportive. The older sibling that's 15 or 16 may watch the younger sibling, help with homework and things like that, so there's more support there and less conflict as the child gets older. Only children tend to have a fairly high sense of self-esteem and achievement motivation as compared to those with siblings. I shall agree with that. I am an only child, but that's just me. Everybody is unique. This may be a result of their increased level of interaction with the parents and other adults. That is also true. So if you're an only child, you really don't have any siblings to be in conflict with. So most of the time, and this is a generalized statement, it doesn't apply to everybody, but most of the time you will find that the only children, they are involved with more adults, where and this may be due to the grandmother or the aunt watching the child while the parents work in the day or the night. Their socialization comes in when they do go to school. They may not be involved in as many after school activities or community activities, but they do get the same socialization. When we look at sibling relationships, you want to understand that if there's a sibling rivalry, this can cause a mutiny in the home. So this is another important thing that we want to educate the caregivers about, that there needs to be some type of balance there as well, especially if you're looking at divorce. Adolescents may want to attempt suicide or take pills or start cutting themselves in an attempt, and they may attempt to do it numerous times just because the parents got divorced, especially if the parents were really close or the adolescent was really close with the parent that is now leaving the establishment. It may lead them to suicidal ideation. So that is a very, very important thing that we want to talk to our parents and caregivers about, especially when it comes to divorce and remarriage. as well as siblings. They may get jealous of the sibling because one may spend more time with the divorced parent than the other. So that's another thing you want to look at. All this kind of ties in together, and it takes a lot of, I would say, family counseling to get this under wraps. We can't be super nurses, so when the referrals are needed, this would probably be a time that referrals are needed and social work needs to come in. But good, open, effective communication skills with the adolescent during this time is key, because a lot of things can go wrong. Again, we say that a lot of things can go left instead of right when divorce happens, or we have the sibling rivalry and the conflict never resolves. So this takes a lot of education and communication skills. So let's look at the almighty peer and how great of an influence they have on the adolescent. Friends have long been considered to be the central importance to adolescence. Boy, do we know that is correct. Because of the developmental importance of peers during early and middle adolescence, friendships experienced during this period are unlike those encountered at any other stage in life, basically. A major concern for many parents is whether their adolescents are being adversely influenced by friends. Well, of course, this can happen if the parents or caregivers don't actually teach the adolescent what is right, what is wrong, and guide them in the direction that they need to go in. But in the same token, depending on who their adolescent is hanging out with, can determine their actions and their influence. Some peers can be very influential, but I understand how parents do not want their adolescents peers to influence bad behavior. Sometimes we cannot help that as nurses. Neither can the parents or guardians. All we can do is educate them on maybe signs to look for, or communication techniques to talk with the adolescent. A major parental concern is that family values will be displaced by their peer values. Although there is some justification for this concern, several factors influence whom adolescents are likely to select as their peers. First, there's a considerable overlap between parental and peer values because of the common backgrounds. Many adolescents select friends whose values are congruent to that of their parents. Second, parents often are unsure of appropriate expectations for certain areas of adolescents' lives and are thus willing to defer to the expectations of their adolescent friends. This is especially apparent in current fashions, music, and leisure activities. And you don't want to scold the child or be like overly protective of the adolescent, especially if you have like a young teen who is, I would say, 13, and they wear maybe heavy makeup and the black gothic clothes. You want to ensure the parents and the caregivers that the teen's appearance does may not accurately reflect their actual values. Okay, this just may be a phase, like we call a lot of stuff. It may be a phase, or it may be their peer influence. So it does not necessarily reflect their values because of their dress. Okay. Third, parents and peers have an impact on different aspects of adolescents' lives. Peers are more likely to be influential in matters of current importance, such as in music and entertainment, fashions and clothing and language, dating and friendship behavior, whereas parents are more likely to be influential in matters of greater and long-term permanence, such as moral and social values, educational aspirations, and occupational choice. Fourth, When adolescents do turn to peers for support, frequently it is not displacement of parental influence, but rather an attempt to fill a void left by parents' lack of support or involvement. That is why we stress that parents are involved in the adolescent's life. Because we can see right here that if they have a lack or a void, where are they going to turn to? Their peers. And most of the time, the information they're getting from them, very incorrect. And you also want to know that even in early adolescence, where they're 12 to 14, you have to understand by 14, many women have the physical appearance of a young woman. Few grow in height after 14. So, a lot of their peers may influence them, in the sexual behaviors, telling them that, oh, you look grown, you can do this, that, and the other, when that may not be the case. They may not cognitively be there, but they look as though they're 18, 19, 20, 21, and they're only 13, 14. So we have to educate the parents and caregivers on what to actually be telling the child so that they don't leave the home and seek out advice from the friends. Caregivers have both direct and indirect effects on the children and adolescents' peer relationships. Caregivers' indirect influence on children and adolescents' peer relationships is thought to generally be a result of the caregiver's interaction with their own children or by parenting behaviors they use in rearing their children. Caregivers can also have a more direct effect on the children or adolescent peer experiences. This more direct influence is a result of caregivers' interactions with or about the child's friendships. Caregivers can directly influence young children's peer relationships in four ways: designing, mediating, supervising, and consulting. Caregivers design children's peer experiences by controlling or influencing the settings in which children are likely to meet and interact with peers. They mediate by actively assisting children to successfully meet and interact with peers. Caregivers supervise by providing oversight or regulation of the children's peer experiences, and they advise children about peer interactions by sharing advice or coaching children about how to maintain more positive relationships. Most research about caregivers' direct influence on adolescent peer relationships has generally focused on the caregivers managing adolescent peer interactions, which is key. But you cannot be everywhere all the time with your adolescent. And if you're too overguarded as the parent or guardian, what's going to happen? They're going to sneak out and do it anyway. So that leads us to dating. As previously mentioned, the youth's passage through adolescence is marked by an increased significance in peer relationships. This process begins with same-sex friendships. However, during middle and late adolescence, young people begin to explore opposite-sex relationships, frequently through dating. A major shift in the dating experience has been the age when it is likely to begin. Dating now typically begins around age 12 to 13 for most girls and between 13 and 14 for most boys, depending on how rigid the parent or guardian is. Although the parent or guardian may strictly enforce that the teen does not date, they may go behind your back and date anyway. So we need to educate the parents and caregivers not to be so naive that they're, overlooking things. As dating becomes more important to adolescents, their motivation for dating and their selection of potential partners do change. When we look at school and academic achievement are important in shaping the development of adolescents' sense of autonomy and identity. In addition, adolescents remain in school for more years now than they did in the past. That is a good thing. Well, I don't know. Sometimes it's a good thing. As long as they're getting educated, I say it's a good thing. Academic achievement during adolescence is important because it often reflects not only how well the individual accomplishes long and short-term goals, but also the feeling of success one has in one's own as well as society's eyes. School is also important because it is a critical setting for adolescent development. In fact, most developmental milestones related to competence, such as academic achievement, involvement in athletic activities, peer relationships, and prospectical or prosocial behavior, are related to behavior or defined in the school context. Schools can have a positive or negative effect on the adolescent. Often a student's experiences varies according to the parent and family context, peer group, size of the school, extracurricular activities, and the actual academic track. An adolescent's adjustment to school is also influenced not only by behavior of his or her friends, but also by the characteristics of the friendship and by the teachers. For some adolescents, school is a stabilizing, friendly force in their lives. It can encourage cognitive development, establish a climate for social interaction, and provide an environment that encourages task completion. School also allows adolescents to have contact with peers and teachers, test new ideas, and validate their thoughts. Activities and opportunities at school can provide safe, acceptable outlets for their energy and foster development. Groups such as the Honor Society, musical and dance groups, school council, athletic teams, school yearbook and newspaper staff, debate teams, special interest clubs, pep squads, cheerleading, and ethnic identity groups give adolescents a chance to participate in activities with young people who have similar interests, provide experiences in organizations working toward common goals, and allow development of cohesiveness and group loyalty. Schools can also help break barriers related to ethnicity, social class, race, and gender. It is more likely to have a positive effect on adolescents if they have close friends during, before, and a transition to secondary school. For other adolescents, however, school can be a source of stress where threats of safety and self-esteem constantly change and constant change occurs. Some adolescents may experience depression, decreases in perceptions of their athletic and academic abilities, or actual academic and athletic performances, dissatisfaction with school, or discrimination based on race, and consequently drop out or skip classes. So, as pediatric nurses, we want to educate the caregivers that they need to be talking with their adolescent child to see how they're actually doing in school. I know sometimes it is not easy to attend these parent teacher conferences and things of that nature, but we have to put in the effort in order to get any kind of results, because if your teen is in some type of mood and they are just not okay with school, we need to find out what's going on. The nurses, as the pediatric nurse, we can work closely with the parents and school officials to provide accurate, objective information related to health promotion activities and issues adolescents are concerned about and see as important. School-based health centers afford unique opportunities for pediatric nurses to provide accurate information and non-judgmental counseling about adolescent issues. Alright, let's look at the health promotion of the adolescent. Any adolescent health promotion needs to incorporate the adolescent's perspective of what health means and consider their priorities and concerns relative to health and healthcare services, as well as their level of cognitive development. Several guidelines are important for nurses to remember when interacting with adolescents. First, the environment should be caring, positive relationships are encouraged, individual differences are valued, and strengths and weaknesses are acknowledged. Nurses need to treat adolescents with dignity and make it a priority to know them as individuals. Assessment with the purpose of improving health, describing health promoting behaviors, and understanding is of course crucial. Relationships with families are important to develop and maintain. This means Frequent communication between nurses, adolescents, and families are encouraging family participation in many health and other issues. Effective nurses also need to know and understand that age, maturational level, and physiological changes have an impact on development, and also understand the specific psychosocial needs and developmental changes expected during adolescence. Confidentiality and trust can be important issues for adolescents, which nurses must acknowledge. Any program developed for adolescents or their caregivers should present information objectively and accurately, and adolescents themselves should be allowed to and encouraged to identify and discuss issues and problems they consider important and provide input into planning. To work effectively with adolescents, nurses should demonstrate poise, tolerance, warmth, and, of course, empathy. Nursing care should be provided in settings sometimes away from the caregivers, where the self-conscious adolescent feels welcome and comfortable. Allowing sufficient time and privacy for all interactions is essential. So sensitive talk related to physiological growth, sexuality, personal goals, and behaviors such as drug abuse, gang membership, and promiscuous behaviors can be discussed in an unhurried and unjudgmental atmosphere. Confidentiality issues should be discussed early in interactions, since adolescents may confide information to the nurses they prefer their caregivers not to know about. So, of course, when we're doing a physical assessment or a health surveillance on an adolescent, you want to first make sure you offer them the opportunity to talk to you alone. They may not want the parent or caregiver there, especially if it has something to do with sexuality or, an STD or something like that. They may not want the parents around. Of course, you as the nurse want to maintain confidentiality and make sure that you build some type of rapport with the adolescent, because they will confide in you when they are not confiding in their peers or even their family members. Also, the physical characteristics that you want to note, such as in your 15 to 16-year-olds, they'll have increased shoulders, chest, and hip width. As the school nurse or even the pediatric nurse, when you're doing your surveillance, you do want to talk to your 14 to 16-year-olds about sexuality and birth control. You want to look at, when looking at behavioral characteristics, you must know that adolescents do tend to take risks, and they are avid risk takers during this time. So this usually enables them to overcome common sense and, of course, their own better judgment. So we do want to make sure we're educating them on health promotion or health maintenance if they have already started to interact sexually. Another thing we do want to look at, and we'll talk about in a bit, is their sleeping patterns. If they're having problems such as stress or bullying, they may have trouble sleeping. To engage in conversation with this adolescent, of course, you want to open up with open-ended questions such as, what are the occasions that this occurs, or what are the occasions when this occurs, and is there a pattern connected? Now, you'll notice that the question I ask is a yes or no question, but it is connected to the open-ended dialogue question that I first presented. So you do want to open up with an open-ended question, especially if they're having trouble sleeping. Another thing that you may encounter are the females wanting to fit in their peer groups. So your female may want or inquire about having bigger breasts, or asking if they're going to grow more. You want to inquire why she wants to know about her breast growth, because by 14 they should have already grown to about adult size. So you want to figure out what's going on, whether it's peer pressure, whether she's trying to impress a male, or something of that nature. Note that these adolescents will confide in the nurse, so you do have to build a rapport with them. When we look at their nutrition, you want to know that iron intake should be increased to meet normally expanding blood volume needs, the increase in lean body mass, and to replace the iron that's lost during menstruation. The adolescent will always seem hungry, but often do not eat appropriately, nor do they eat well-balanced meals. Instead, they'll prefer snack foods that are easy to prepare, popular with their peers, and often full of empty calories. For us as nurses, we can help the caregivers and the adolescent improve their nutrition by explaining the importance of a good diet and encouraging the adolescent to be involved in their meal planning. Caregivers need to realize that the adolescent's need for freedom, independence, and peer acceptance may be reflected in their eating habits. So they may want to eat the french fries just because, all of their friends are eating french fries. So they may just want to fit in. At least 3 issues related to nutrition may surface during the nutritional assessment. One may be obesity, another will be anorexia or bulimia. So those are very important topics that you will want to speak with the adolescent about, as well as the caregiver, especially when taking care of these things or seeking further help. I believe if the adolescent does not know what's going on or how to treat it or why it is occurring, that the problem will persist into adulthood. When we're looking at the oral health during adolescence, dental visits are usually twice a year. Good oral hygiene habits usually have been established, and the majority of the orthodontic work has begun, and most of the permanent teeth have erupted. The third molars or the wisdom teeth, however, may erupt later in adolescence. Most of the time, it's usually like between 17 and 21 that their molars will go ahead and grow in. Dental trauma is usually common in males. Why is that? Usually because of the contact sports that they play, so we want to make sure we educate on that. And of course, sleep and rest. Adolescents need approximately about 8 hours of sleep per night. They need daily exercise to provide an outlet for tension and anxiety and to maintain muscle tone and development. Regular exercise will also promote healthy sleep patterns and enhance emotional development. When we talk about activity, most injuries involve falls or being struck by or against objects. Injury rates are higher, of course, for males and even non-contact sports. Soccer, basketball, baseball, and bicycling may result in head injuries and collisions with other persons. As for the nurse's job, we can help adolescents increase their physical activity as appropriate to meet the physical activity guidelines for adolescents and to avoid injury by considering the adolescent's physical development and their capabilities. We need to inquire about the adolescent activity program, including frequency, their vigor, and preferences before making any recommendations, as well as determining their tenor staging. As nurses, we can encourage them to get involved in sports, recreation, active play, or even exercise at home, at school, or in the community. Alright, finishing up with safety and injury prevention for the adolescent. Almost 1/3 of deaths occurring in individuals between 16 and 19 are caused by motor vehicle accidents. And drivers in this age group are 4 times more likely to crash per mile than any other driver. Therefore, accident prevention and safety promotion programs are extremely important for the adolescent. When we look at risky behavior, or before I even talk about risky behavior, let's back up and talk about motor vehicles. When we look at the teen and allowing them to operate a motor vehicle, I'm afraid most of the time I want to move out of the way. But I can't say that because I too once was a teen. So as the nurse and both as the parent and the caregiver, you want to make sure you're educating them on safety, basically. especially if they're going to operate a motor vehicle such as a motorcycle. You want to make sure they're wearing a helmet, long pants, full body covering, and this doesn't mean like a full body suit, but I mean, of course, covering their arms and their legs, and wearing and making sure they learn all the relevant rules to operating that type of vehicle. So you want to make sure they know the safe rules and regulations, because some parents are allowing their teens to start driving as soon as they can, which is, 15 and 16. So we want to make sure we allow them on the road, but we want to make sure they're safe when they're doing it. When looking at risky behavior, substance abuse is one of the major risky behaviors that we look at, and smoking. But substance abuse is a maladaptive pattern of alcohol or drug use resulting in significant distress or impairment. Onset often occurs during adolescence and is related to several factors, including positive family history, negative life events, ineffective coping, dysfunctional family relationships, and of course, psychiatric conditions such as ADHD, depression, and conduct disorders. When we look at smoking, this is another risky behavior seen during adolescence. This is considered a risk taking behavior because adolescent smokers are more likely than their non-smoking peers to sell drugs, drop out of school, use marijuana, and other hard drugs, experience early pregnancy and parenthood, and have multiple drug problems. Those adolescents are also at risk for using predatory or relational violence, low academic performance, behavioral problems at school, and stealing, and other delinquent behaviors. It is positive related to advertising, parent smoking, and portrayal of smoking in films, as well as access to tobacco products in the home, and rather a close friend or smoking siblings. When we look at violence, older adolescents are more likely to be violent than the younger teens. Males are likely to be more violent than females. I wonder why. A number of variables are related to violent behavior, including family factors, individual factors, economic factors, and, of course, societal and environmental factors. Violence is a great threat on the lives of adolescents, and those exposed to violence when young are likely to develop depression or PTSD, which hinders development. Those factors identified as protective when exposed to violence include social support from peers and adults and connections to school. Another safety and injury prevention we're going to look at is sexual activity. Sexual decision making and behaviors are traditionally controlled by family and societal values. Adolescents' reasons for becoming sexually active include, but are not limited to, feeling grown up, to enhance self-esteem, to experiment, to be accepted by friends, to have someone to care about, love, and be close to, for pleasure, to gain control over one's life, to seek revenge, and to prove that they are normal. These are all valid reasons that one may seek out sexual experiences. Predictors of early sexual activity include lack of attentive or nurturing parents, early puberty development, poverty, sexual history of use, cultural and family patterns of early sexual experiences, poor school performance, lack of school or career goals, and dropping out of school. Sexually active young people participate in behaviors that put them at risk for sexually transmitted diseases and pregnancy because they frequently have multiple patterns or do not use condoms or other forms of contraception. That is where education comes in. When we look at homosexuality, adolescence is an important time for developing one's sexual orientation. On average, gay teens come out before or after high school graduation and have their first sexual encounter at about age 14. In contrast, development of a same-sex orientation for females is likely to occur later or more abruptly. Nurses need to recognize that even though many young people explore their own sexual orientation or homosexual attractions, few who engage in homosexual behavior during adolescence continue the practice into adulthood. So this is one of those times that people, I would say, are experimenting and they're trying to find their sense of identity, and they may just try some things. This may persist into the late adolescence or even early adulthood when they go off to college. So as nurses, we just need to educate them about that and need to help the young people recognize that homosexual experimentation is not the same as establishing a homosexual orientation, and phrase questions about sexual and sexual activity very carefully but also very respectfully. Lastly, when we look at the effect of television and other media, of course, it can have a great adverse effect on the prosocial or positive outcomes of the adolescent. We just want to be mindful of basically what they're watching on TV. Limited to about 2 to 3 hours a day if you have any control over that. I mean, because now they have access to TV on their phones, on their iPods, on their iPads, on their iPhones. I mean, it's just ridiculous how much technology has evolved, and so really you can't really limit it unless you have that sort of control over their gadgets. So we do want to educate or monitor. We want to educate the parents to control or monitor the media programming that their teens watch because of all the violence, the sexual behaviors, and things like that. Remove the television sets from the bedrooms because they're on all times of night and they're not going to bed, they're not studying. Specifically, this means to limit all media use to no more than 1 to 2 hours a day, view televisions with the adolescents, and monitor their child and adolescent use of media. Because as we can see, these social media networks such as Facebook and Twitter and Instagram and Vine and all of these other sites I have not even heard of are available for, everyone to use. And there's some crazy people out there, so they prey on, these adolescent children, whether it be male or female. So, we need to educate the parents or caregivers not to be naive about all the media that is available to these adolescents at this time, and that they need to monitor very closely what their teen is doing, because oftentimes if they're not aware or they're not vigilant about seeing what the teen is doing, then the teen can get in a whole lot of trouble or even go missing or get killed or things like that, because we have some very crazy people in the world. So it's just going to take a lot of education. But when you're educating this age group, you want to not only educate the parent and caregiver, you want to actually educate the adolescent as well. Alright guys, so this concludes chapters 11 and 12, which was an overview of growth and development for the school-age child and also growth and development for the adolescent. I hope that you have listened to each chapter and you have taken notes accordingly. Please take heed of the examples that I provided in each chapter as you may see or hear them again. And as a review, you can study the review questions that are in the back of each chapter, as well as your workbooks if you have purchased them. good luck and look forward to working with you in the next 3 chapters, which will start on chapter 13. Okay, guys, so that does it for chapter 11 and 12. And hopefully you will be able hopefully you'll be able to watch this with no problems. Hopefully it uploads with no problems. And sorry about, I don't know what ended, but that was the end.